everyone. My name is Haseel Bhatt. I'm a physiotherapist and researcher in the area of movement disorders. Today, I have the privilege of speaking to Jordan Bedime. He is a PhD student in kinesiology sciences at McGill University in Montreal. He works at the Human Brain Control of Locomotion Lab under the supervision of Professor Caroline Paquette. Jordan specializes in biomechanics and neuroscience and studies gait impairments in Parkinson's disease from both a neural and behavioral perspective. Jordan's doctoral thesis focuses on fatigue and Parkinson's disease and its influence on how the brain controls locomotion. Jordan is also a neurological physiotherapist by training. After completing his professional bachelor's degree at Lovely Professional University in India, he specialized in the management of neurological disorders, including neurodegenerative disorders like Parkinson's disease at KU Leuven in Belgium. Jordan's first research experience was indeed during his specialization master's, wherein he studied under the supervision of Professor Alice Neubauer, freezing of gait, a very disabling symptom of Parkinson's disease. Jordan was born and grew up in Cameroon. Alongside research and clinical practice, Jordan has become an enthusiastic educator. He aims to connect and contribute to the community. Thanks for doing this.
Thanks for having me, Haseel. It's a pleasure to be
So,
here.
yeah, I am so interested in your research. I think it's a really important but overlooked topic of fatigue. Maybe before we dive in, we can talk about how you and I connected. Do you want to share how you and I maybe touch base?
Yeah, so as far as I can recollect, I was browsing on my Instagram profile, my professional one, and I saw your post. You were having some kind of quiz going on. I can't really recollect when I started following your channel. That day you were having a quiz. I think it was about the UPDRS, and I was answering. And then you replied
That's
that you told me, "Oh, you got everything correct," and I was like, "Yeah, repetition is the mother of science." And then we started talking, exchanging messages. I realized you were a physiotherapist, and you were in Toronto. And then we planned to meet at the MDS conference in Toronto. I actually
right.
didn't know you were going to be there. I told you I was going to be in Toronto, and I wanted to have a chat with you over coffee. I was very
Yes.
happy and surprised you were at the conference.
Is that you were one of the speakers there as well. You
Yeah,
doing
yeah,
a presentation. Which
yeah.
is so yeah, I think I kind of love social media that there is like a little nook online where people can learn and be really interested in one topic and they can all sort of gather together, and that's around the world. I think our stories actually mirror each other in some ways, being able to go around the world and learn from some of our mentors, specialists in this area. And for me anyways, like the perspective of how I look at Parkinson's care has really been shaped by those experiences. Would you agree?
Yeah, I would agree. I would say I was quite pleasantly surprised that you were also African in some way.
Yes. At one point, I spoke Swahili, but I don't. Now it's only a few words here and there. And then you studied in India as well, so that's super interesting. So all over the world. But I really want to get into this topic of fatigue because I think not only does it affect folks with Parkinson's, but all neurodegenerative condition. How did you get into this area? What sort of drew you in to want to study this a little bit more?
Thanks for asking that because when I came here to McGill for a PhD, I had a completely different idea of what I was going to do in my PhD thesis. Like you mentioned, I got interested in research back in Leuven in Belgium. I was supervised by Professor Alice, and she's an expert in freezing of gait. So that's how I got interested in Parkinson's disease research. I got in contact with my current supervisor here at the Human Brain Control Locomotion Lab. And when I came, essentially was to continue my interest in freezing of gait. But at the time, there was a project already going on initiated by a previous postdoc in the lab, Audrey Parent, which eventually had got another position. So she left. When I came in, the project was going on, and Caroline proposed to look at it and see if I would be interested to looking more closer into fatigue. So it was quite serendipitous.
Yeah,
I hadn't planned it, and interestingly, I also, being in research, knowing a little bit more about Parkinson's, I wasn't really aware of fatigue as such an issue in these populations. That speaks to how much on the acknowledged it is, on the recognized this symptom is, even in the research
right.
field.
I love that story. And sort of a fun tidbit, I was very privileged to meet both Alice Neubauer, who was your professor, and Dr. Carolyn Paquette. It's so funny how the Parkinson's world is so connected in a way. Is
Yeah.
Let's talk about at a high level, what is fatigue and why is it important for patients and healthcare providers to understand fatigue in neurodegenerative conditions, particularly in Parkinson's disease?
Well, I think that to me the first reason is really what we talked about in the beginning, the fact that historically it's been so neglected, right? And
Mhm.
although I would say in the past 20-25 years we've learned a lot, so it's more and more recognized in research particularly, but we can't really speak the same in clinical practice or at the patient level. You know that knowledge translation is always an issue in research, regardless of the topic. So I think the main idea here is for people with Parkinson's disease and clinicians, particularly physiotherapists, to kind of get more acquainted with what fatigue is, being able to describe it, report it, and really put it at the among at the center of the table among the other uh, prevalent symptoms. I think the other point also is to really advocate for patient engagement, because yes, we've learned so much compared to 25 years before, but there's still much that's needed to be explored, and that only it's not like a one man job, so it takes everyone to to bring new information. Yeah.
I think one of the things that I'm always struggle with, or it's this balancing act of doing research and then clinical practice and then distilling all that down for the patient, right? So, in your words, in a few sentences, I know this is a hard task. What is fatigue in your and
Well, not just in my word, I would say we like researchers have really managed to come to a quite accurate definition. We better at describing it, so to defining it. So it's more or less seen more as something that's subjective compared to let's say a a capacity decrement in like a muscle weakness. So we know it's different for that. More, it's more subjective. It could be mental or physical, but there seems to be that subjective component, um, and particularly a perception issue in the effort that someone needs to perform, to provide in order to perform an activity or a mental task. So I would say fatigue for me is a subjective experience that relates to how someone feels about the amount of effort and energy he is or needs to put in a particular activity or mental task.
I love that. Okay. And that is quite prevalent in Parkinson's, but from your research and the research that you've shared with me, that's the umbrella term. And then if we zoom
Yeah,
in, there is physiological fatigue and pathological fatigue. Can you explain what those two
yeah.
things are?
So physiological fatigue would be what we'll call it normal fatigue. So let's say you go have a heavy exercise, you run a marathon, and at the end you're fatigued. So that's something we expect. It's normal to us. Now pathological fatigue, it's something that we don't really expect, or it's beyond what would expect to normally see after an exertional task like running or doing a heavy mentally loaded activity. So that becomes pathological. And in that category, we have what we call subjective fatigue, or just fatigue, like the fatigue that is predominantly related to Parkinson's disease, have this nature of being subjective in nature, whether it is related to physical activities or related to mental processes and mental tasks. And
Mm,
there's also another kind of pathological fatigue that is more related to peripheral fatigue, or or fatigability, or performance fatigability, and that one seems more objectively measured, where you can really objectively measure a decrement in performance, or in muscle force. That one is more related to dysfunctions at the neuromuscular junctions, muscle fatigue, perhaps, but not subjective fatigue, which is more what we refer to when we talk about fatigue and Parkinson's disease, and some neurological disorders. I would say that pathological fatigue, so subjective, and fatigability, can be both present in many neurological disorders. For example, in multiple sclerosis,
mm.
you have both. But in Parkinson's disease, it seems to be more the subjective fatigue that's prevalent. Yeah.
Interesting. And so, in the subjective fatigue, when we talk about subjective, is people's perception or how they describe their fatigue. But I was so surprised to hear and read that they don't call it fatigue. Right? Can you talk a little bit more about how they describe this subjective fatigue?
Yeah, the patients, or the people living with Parkinson's, they use various kind of words to describe how they feel. They can say they're tired, they're exhausted. Usually, what rings an alarm is the intensity of the way they feel. They would say, I'm extremely tired, or I'm exhausted. So there's still that element of severity. And then another indicator would be how frequent it's fatigue that happens almost on a daily, right? Fatigue that doesn't go away by sleep. So I would say there is a broad spectrum of how they define it, or I mean how they describe it. They don't necessarily say I am fatigued. Um,
Yeah.
I don't think that's common language. Even for me, I'll say I'm very tired, I'm exhausted. But yeah, there seems to be that element of you know really really intense feelings of exhaustion. Yeah, that do not get
And
relieved by many of the strategies they try, including sleep. So,
so that's an interesting point. You said it's not relieved by things like sleep, or it is.
like, it's not. So
Mm,
they would complain of fatigue that they can't really sleep away. So they would wake up. They could sleep for extended period of hours. Well, some have some relief, but in the long run, that fatigue doesn't go away. So one core characteristic of fatigue in Parkinson's disease is how constant it is. They might have some daily fluctuations, but over the long run, it's something that starts also very early in
mm,
the clinical diagnosis. Sometimes even before. Sometimes it might be one of the symptoms that are reported
mm.
before, at the time of the initial diagnosis. So, yeah, very constant and intense.
I think that's such an important clinical point. When somebody comes into the clinic using this language of extreme exhaustion, clinicians may say, "Let's look at your sleep." But I think this is a really important point because perhaps if sleep is not a thing that will replenish or manage the fatigue, how where would we go? Now I'm going to get you to take your research hat off and put your physio hat on, even though those two are the same. If you had a patient like that, would you first start with an assessment around the fatigue? What probing questions would you want to ask Jordan to really tie into, is this fatigue more sort of subjective, which is more common, versus fatigability, like you've described? What would you want to add?
The Parkinson's disease is a very complex disease, but when about fatigue, um, definitely I'll try to really rule out other potential causes to really make sure it's we're dealing with fatigue that is primarily caused by Parkinson's. You know,
Mm.
so we're going to rule out muscle weakness. Um, are they taking medication that could potentially cause fatigue? I think you won't rule out sleep completely because we know that sleep issues causes fatigue. So you want to rule out all those. Um, I think in the general pictures, there are multiple factors that could contribute, and there are probably multiple types of fatigue. But you want to identify the dominant factor, and in terms of Parkinson's, you want to make sure if you're really dealing with fatigue related primarily to Parkinson's disease. So the first thing is distinguishing it from fatigability. So
Mhm.
really, peripheral fatigue they also call it. So for that, you so there are many ways to first apprehend fatigue. So you could look at it as a trait or a state. A trait would be more how the person has been feeling for an extended period of time. Let's say past 1 week or 2 weeks. While a
Mhm.
state would be more how the person is feeling now, right? So you can measure both ways. So your patient tells you, "Hey, I'm feeling fatigue." You could use maybe a simple visual analog scale, Likert scale to measure that, and you can link it maybe to an activity. Let's say you have a therapy that you're giving, and then you have the same state assessment at the end, and
Mhm.
you can, in parallel, also have an assessment of muscle strength, for example, to really make sure that it's not really a capacity decrement. It's you want to make sure that it's really something that's subjective and there is no muscle weakness going on. Anything, yeah, more structural, um, yeah, something like that. And then you could also extend it to more trait measures. So they are developed and validated questionnaires for fatigue. Some are more recommended for screening, others are more recommended for measuring the severity, some are recommended for both. So you could go with that. But the main thing is, yeah, ruling out all the potential causes of fatigue. I mean, not ruling out as if they are not there, but they are not the
Yeah.
dominant contributing factors, I would say.
Actually some really nice tips. So I think the visual analog scale is sort of globally something that physiotherapists understand and use. And so if
Yeah,
they won't, that could be just a simple thing of 0 to 10. What is your level of tiredness or fatigue?
yeah.
And then if there's a big change or a big delta or an increase in that number, then perhaps it is sort of exertion based and it is clinically you're thinking more fatigability or peripheral fatigue. Am I right so far?
I would say
Perhaps.
I would say it depends. Perhaps then you don't really know. I would say you would really need to try to link it with a measure of performance itself, so you can compare where which one is driving that. Is it just a subjective feeling um, that's associated also with a true decline in the capacity? Do you see some peripheral issues as well? Yeah, that's why I was talking about. You can measure like isometrics, for example, and see if well you've done your aerobics, you've measured isometrics before, you've measured the visual analog scale for subjective fatigue, and at the end you do the same, and maybe you see that well the isometrics is not really that different. So there isn't really a huge decrement in muscle capacity compared to the amount of decrement in subjective fatigue that you see with the visual analog scale. Well, and that is still crude, that's still a crude measure, the visual analog scale. But from there on, if you repeat it once and twice and you identify a pattern, you could, use more validated scales. They also like performance measures that are validated and they have, really um, cutoffs, like minimal clinically important differences. And they have been validated. I'm not really sure in the Parkinson population, but in the multiple sclerosis population, they have been validated a lot, where you can actually, let's say, the 6 meter walk test, and you really
Mhm.
look at the decrease in performance in terms of distance walk from the first minute to the 6 minutes. And then there is like the percentage change cutoff, beyond which you can't really suspect fatigability, because you would also expect someone to get slower after like 5 minutes, every individual. But
Right.
I think there are valid measures for when that decrement in performance becomes pathological. um,
Mm.
so so they could use those performance measures to compare and try to rule out fatigability from subjective fatigue, or maybe they both. It's not excluded as well, even in Parkinson's.
Starts making me think about these correlations or increased likelihood of describing extreme tiredness with other non-motor contributing factors to Parkinson's. One that
Yeah.
comes to mind is low mood or depression, anxiety. What can you tell us about sort of neuropsychiatric symptoms or even non-motor symptoms that come part and parcel with fatigue, maybe even apathy?
To me, it's the first one that comes to mind. Apathy, with a motivation, decreased motivation, and increasingly that's being linked to the pathophysiology of fatigue. I think apathy is a big one. Obviously, depression. We know that fatigue is one of the. It's also one of the criteria for diagnosing depression.
Oh,
So depression, anxiety, um, I would say fatigue is associated with many non-motor symptoms. Um,
right.
in terms of motor phenotypes, say that fatigue and non-motor symptoms in general are more associated with a more rigid kinetic type or postural instability compared to a tremor dominant type. But
So
having said that, those links with the other non-motor symptoms exist, but they aren't that strong. So we know that fatigue is regardless an independent symptom. So the prevalence rates of fatigue are not modified with the prevalences of the other symptoms, for example. We know that it's quite independent of disease severity as well, although it tends to increase in severity with time. By and large, it's quite stable, I would say.
I think you hit on a point which made sense to me when you're talking about phenotypes in Parkinson's. And the phrase that comes to mind is Parkinson's is not a disease, actually, it's a syndrome, right? And that one person with Parkinson's may look very different than another person with Parkinson's. And when we talk about phenotypes, you said, the rigid, kinetic, gait or postural instability phenotype, which is basically a fancy word that researchers use for presentation,
Yeah.
presentation, and sometimes but then there's the tremor dominant, where one of the first initial symptoms is typical Parkinsonian tremor. And
Yeah.
I think that distinction is important for clinicians to recognize. If you have somebody and you ask them, and sometimes I will ask them, what is some of your first symptoms that came up? If they're saying more of a tremor versus a gait, I may be looking at the evolution of their Parkinson's very differently, perhaps, right?
Yeah.
As a sort of screening tool, even just making that distinction. If somebody is having gait issues, freezing, shuffling, festination, what you said was really important. I want to highlight that those patients may have a greater vulnerability of experiencing more fatigue than a tremor dominant Parkinson's phenotype. Is that somewhat accurate?
Yeah, in terms of probability, I think that's definitely accurate. Well, that's what the literature says, at least.
But I think in movement disorders, what I feel is really important is starting pattern recognition. And for the clinician, if these are sort of patterns that are popping up in the patient or the client in front of you, thinking about fatigability and like what that means. You and I share this interest in freezing and gait impairments. And we had a
Yeah.
really interesting conversation because I'm really interested in freezing. This is sort of an area that I deeply studied for a couple years. And we started talking about your work when fatigue and then freezing. And maybe we should write this up, but is freezing a trigger for fatigue? Oh, sorry, is fatigue a trigger for freezing? What are your
Yeah,
thoughts?
potentially. Potentially, there isn't really, well, compared to freezing, there isn't a lot on fatigue, and there isn't really much um, on both symptoms, where they are exploring the relationship between both. But there are a few, and there are a few studies where people with Parkinson's disease have reported freezing. I recall about 70% of the time when they were feeling extremely tired and
Mm,
fatigued. So there is a potential direct link there as fatigue being a trigger for freezing of gait, but this isn't really explored yet. I'm personally interested in exploring those links with freezing of gait. One link that is for sure present, although indirect, is that we know that freezing of gait causes falls, it leads to falling and fatigue, whether it is primarily with fatigability or secondarily because the more you fatigue, the less you engage in physical activity, you adopt more sedentary behavior.
mm,
Unfortunately, that leads to secondary deconditioning, which
mm,
contributes against to falling. So that's the link, and the real issue for me, and something that's a fact, is that freezing of gait and fatigue are prevalent symptoms of Parkinson's
mm.
disease. That means that there is a good proportion of people with Parkinson's disease that will have both, and that's to me something of concern and something that we should pay more and more attention to, at least due to the consequences when you think about fall and fall prevention, especially that we still don't know how both of those symptoms happen. Yeah,
And there's a lot more questions than answers in this space, but
yeah,
I 100% agree with you, and we'll put it on record right now to say
yeah.
that heat is a trigger for freezing. I'm going to say it anyways, and I think you'd
I,
probably
I
agree.
believe, I believe, I believe it is personally. I believe it is. I also believe there's much to be explored. That's something I'm willing to look into, possibly within the context of my thesis. Um,
Amazing.
Depends on many, or if not after.
Over the 15 years I've been working with folks with Parkinson's, I've seen a complete shift of how we deliver rehabilitation. And when I first started, this is when the Cochrane Review talked about exercise and physiotherapy as a modality for treatment for Parkinson's. At the time, there was not a lot of push to have patients engage in exercise and physiotherapy until they're falling or if they're having some freezing, they get a referral. Around that time, it was almost like don't push them too hard because they would fall. Right? It was like don't give them some few exercises, keep folks loose, you know, try to
Mm,
maintain. And then the Cochrane
mhm.
Review completely changed. And then they revisited. There's some short term improvements. And now we're seeing work from Margaret Mack looking at some of the long term improvements that are coming out. Then we see things like the Sparks trial, if you're familiar, some of the gait studies that are happening to push patients, high intensity exercise. So we've gone shifted the pendulum on the other side. And I think that's where we're kind of living.
Yeah,
And we're noticing really beautiful outcomes that are coming from high intensity exercise in Parkinson's. I think, though, when it comes to fatigue, the high intensity exercise, that fatigue piece is not appreciated enough, particularly around those who are freezing and falling, right? And I think we need to strike a little bit of a balance in terms of giving folks living with Parkinson's disease some permission for rest and recovery so that we are not putting them over the edge to freeze and perhaps even fall. What's your take on that?
I think the main issue with finding strategies with fatigue, or with the way people deal with fatigue and people with Parkinson's disease deal with fatigue, there are some misconceptions that are related to how we define fatigue. For example, the fact that um, too many people think that fatigue prevents you physiologically in terms of capacity to engage in activities. That's not the case, so we know that it's more a subjective feeling. So you don't really have a decrease in capacity. You might have it, but when we talk about primarily fatigue related to Parkinson's disease, it's more subjective. Shifting, changing those beliefs and understanding that fatigue doesn't primarily prevents you from engaging in those activities from a capacity point of view. I think that's the first thing to take. The other thing is that more and more we think of fatigue as being linked to decrease in motivation, decrease in the capacity to maintain attention for a long period of time on an activity, whether mental or physical. And when it comes to physical activities, it seems more germane to those activities that require of initiation, so internally driven activities. So that's why I think apathy is a big non-motor symptom that's related to fatigue and depression as well. The thing with exercise is when we look at the evidence, it's the only candidate that has shown some, although limited still. When you look at the amount of literature that's out there, it's the only candidate that's showing some effect on
Mm,
fatigue. The other issue you pointed out is there are some people with Parkinson's disease that report that exercising increases their fatigue. Um, the issue is that the picture is very complex. So you also have depression, and you have other mood disorders, you have anxiety. I think to me, the key point is be more physically active, engage
mm,
in activities that you like, because we also know that from, let's say, the physical activity research, that you get the most benefits of exercise when you enjoy it. So you can
mm.
run a marathon, but if you're in the wrong mood, you don't really reap as many benefits as, let's say, if you're depressed. Um, so we know that exercise helps with depression, but if you're too depressed, too in a low mood, and go have a run in the morning, that might be detrimental. So knowing that we're dealing with motivational issues, something that has more of a behavioral component, I think doing too much of a high intensity exercise where there's no enjoyment, where really pushing too hard, and there are comorbidities, there's freezing, there's posture instability. I think the most important is to provide the safe training environment for for the person with Parkinson's disease, and really think about motivation, mood, enjoyment. I think it's more providing strategies and intervention to increase engagement in physical activity with the right mood. I think that's a barrier with exercise, and how we approach it, how we approach exercise, and maybe that's where we kind of miss the effect of exercise on fatigue.
I think one of the things that I ended up taking in terms of professional development for myself is motivational interviewing these patients. What do you enjoy doing? What are your hobbies? And if there is a way to piece the clinical picture together with an activity like you've described that is of value to them, that makes their life easier, and that they enjoy doing, it's likely that they're going to be doing it more for long term because you've described this as a progressive neurological condition. Management is needs to be embedded in daily routine. I I think that's really an important component. You did talk about the research and how exercise as a modality starting to show some good evidence to manage fatigue. Understanding what type of exercise is typically researched, and or you can answer the question, what type of exercise is the best for fatigue?
Well, the people have surveyed the research, so the evidence is not really in favor of a specific type of exercise. So it's quite heterogeneous in that regard. So we don't really know which type of exercise, but if we think about all the non-motor symptoms, let's say mild cognitive impairment or depression, you could think more of resistance-based training and or maybe a mix of resistance exercise with cardiopulmonary training. We
Mhm.
know that resistance exercise is probably more relevant when it comes to cognitive resilience and cognition. So yeah, but to which type of exercise is better for fatigue, we don't know. I think there isn't enough evidence for that. Um, but exercise as a general term, I think that's also a limitation with with exercise trials.
Right.
The fact that well, when we really are not aren't yet there at knowing which type of exercise precisely, how many times a week, what's the volume. But I think it's coming.
Yeah, and I think that it's just a challenge to study exercise,
Yeah,
isn't it?
yeah,
Rather than these medication trials, it's like you give these medication, which is said, but we just talked about earlier today how like phenotypes are different, and people
yeah.
aren't necessarily only enrolling tremor dominant, honing yard scale, looking at neuropsychiatric symptoms and those profiles. I'm impressed that there's so much literature still coming out and still showing benefits. After this conversation, even using the topic of fatigue, the profile of fatigue may look very different from patient to patient,
Yeah.
right? And pulling together an exercise program that considers that profile of fatigue for that specific person. So I
Yeah.
think it's really complex. And so to study all that into cohorts to have one single outcome,
I think
it will be very
that's where that's what research um, lacks right now. We I think there's been this intention to go more to ideas of subgroups and maybe individualize therapies, but when we do research, we want to group people into, we want to rule out, prune away people we don't want and be very selective with our criteria and measure some parameters and exclude some others. And it doesn't really reflect the daily clinical practice reality, right?
the reality.
So when you translate the knowledge from research, I think it's important to yeah have that knowledge in the background, but also really try to treat the individual patient as as a unique condition, a unique case of Parkinson's, and really have that clinical reasoning and try to identify the dominant um mechanisms, let's say for fatigue. We know that it's linked to other non-motor symptoms. Um, Try to link it with motor symptoms as well, maybe freezing. Do not assume, ask the person you're taking care of. Do you experience freezing? When do you think it's related to fatigue? Is fatigue an issue for him? Yeah, and also think holistically. Sleep, it's important. People with Parkinson's disease have sleep disorders. I would say, for example, there are some indication that sleep might help. I
Okay.
think sleep helps with fatigue in general, but when we talk about pathological fatigue, I think sleep might help, especially if it's someone that has, let's say, sleep disorders, and it's a dominant mechanism for the fatigue. We see that women, for example, they report more severe fatigue, and then when you look at surveys, you see that, and you ask people with Parkinson's what are their strategies, you see that on top, one of the top strategies is doing nothing and just engaging in sedentary activity. But what comes after is, resting, or sleeping, and then you'd see that, um, those are strategies that are adopted more by men compared to women.
Mm,
And then I ask myself, is it that women, they engage less in taking, in planning their rest? Gender also plays a role. Gender roles, maybe they have less opportunities to rest.
mm,
So think also of sleep as a strategy. Plan it out. Plan also your activities. Pass them away. Like pacing, um,
mm,
time management. Plan your naps, plan your sleeps, plan your activities. So I'd say I would recommend, instead of running on a long period. Let's say if you plan to do exercise, instead of doing a 1.5 hour exercise straight, you could incorporate breaks, plan breaks, so that you kind of segment your activity bouts and not have to being active for a long period of time, and plan like micro breaks. There are studies in the physical activity, in the ergonomic studies, that show that, just being at work, walking, and taking a 30-second to 1 minute break where you just stand for 1 minute and sit, it really have that, effect in reboosting, revigorating you, and it seems to be significant. So taking those little ideas from physical activity, behavioral studies, and try to integrate it and find ways and strategies that are meaningful for your patient. So to kind of get more engaged, I think shift the paradigm from decreasing fatigue severity and get I don't want to feel fatigued anymore. I think we're not there yet in knowing why fatigue happens, what are the mechanisms, how can we stop that. I think it's probably coming, but we already know that it's more of a subjective thing. So kind of promote physical activity and kind of reduce the negative impact that subjective feeling of exhaustion has on daily activity and independence, because we think, oh, we can't do this because I feel so exhausted, I can't do anything. And in the long run, there is secondary deconditioning. I think it's more dealing with the impact that fatigue has on physical activity, sedentary behavior, uh, dealing with motivation, motivating patients to exercise, activities to enjoy. I think that's more the clinical approach that we ought to take.
yeah. I mean, there's so many gems in there in terms of clinical takeaways for healthcare providers and people living with Parkinson's. Let me just summarize. One of the things I really liked about duration of activity is breaking them out into bouts, right? Thinking about planning your day in such a way to optimize, not necessarily bringing down the fatigue, but being able to do activities in spite of having these symptoms. The other thing piece I really like is, if we're able to incorporate some strengthening exercise or aerobic exercise, but not necessarily in a traditional way. Some people love to go to the gym, they love strength training, they love to jump on a treadmill, and that brings them a lot of joy and enthusiasm. And we encourage those folks, absolutely. I also see a group of folks who enjoy going on hikes and bird watching and doing all these things, but it requires them to move their body in a
Yeah,
meaningful way. So I think piecing those things together holistically, I love that word, in terms of what is going to get somebody to move their body in a way that they enjoy.
yeah, yeah,
I I think The other piece that we talked about was really important, although sleep not may not necessarily be a replenishing thing. Optimizing sleep, okay, is really important, because if you don't have good sleep, it makes all symptoms worse, in my
Yeah,
opinion.
all of them, all of
All of
them.
them.
Yeah,
Talk to any folks with any neurological condition. If you have a poor sleep, the next day is not as good as the day that you had a full night's restful sleep, right?
yeah. And you mentioned it before as well, something similar to cognitive behavioral therapy, maybe more
Mm,
in a casual way where you really talk with the parties, with the patient, and try to get. Sometimes you don't even get to ask patients themselves what they want, how they're feeling, what are the barriers. I think building that therapeutic alliance and communicating with the patients might help also identify some of the needs, some of the opportunities to therapy.
mm.
Yeah.
You've segued so nicely from a clinical standpoint. Some practical tips that clinical clinicians can take away is sort of see beyond what exercises are you doing, but dive deeper into motivation. How are they
Yeah.
feeling about engaging in physical activity and exercise? And one of the best things to manage apathy in Parkinson's is to schedule something in, right? Is optimize that piece and schedule something in when they are at peak dosage, right? Some clinical takeaways, and I'd love for you to add to this, is using this motivational interviewing approach, building that therapeutic alliance. You described earlier so nicely a majority of folks, this is a subjective experience of fatigue, and breaking that down and doing an assessment, whether it be a simple screen for visual analog scale, manual muscle testing and strength, building out the exercise, and then doing it at the end to kind of tease apart where this fatigue is being driven from. What are some other clinical tips that you would recommend?
No, I think I've shared most of what is important. What I would add is you can always go beyond, think about nutrition, an expert. Patients can always think of those strategies that the general population thinks about when it comes to fatigue. Then I would say you seek expert assistance. So to go towards a nutrition needs. If you think maybe you're not eating healthy enough and it's not providing you enough of energy, because it might be the case as well. So look at that.
Really optimizing, it
Yeah,
sounds like.
yeah.
Because what I've taken away from our conversation today is that it's complex, multiple
It's,
drivers. It's a bit of a web in a way. And so if we can optimize pieces that we know to sort of drive up that experience for patients, that and better manage it, then
and
be
finds
impressive.
something
Yeah,
that completely deals with it.
absolutely. Jordan, this was awesome. I mean, you're doing some really wonderful work. I want to give you some space and time to share any last thoughts. If people are interested in reaching out to you, or even from a recruitment standpoint to get involved in some of the studies that you're doing.
Currently, we aren't running any study, so we're done with data collection. But
Congrats.
just in general, I'd really encourage people to engage in research. If you're someone with Parkinson's disease and if you have fatigue. I think today you really get an idea of what fatigue is. You can describe it better to your practitioner, to your physiotherapist, and maybe together work together on strategies on how to overcome the negative effects of fatigue in your life. So in our lab right now, we are analyzing data on the project that we recently wrapped up. So what we did is we brought in some participants, people with Parkinson's disease. Um, we gave them some activity monitors that they were wearing at home for like 5 days, 5 nights, and in between they came to the lab and we did some PET. So we did some nuclear imaging during walking. So they walked for like 20 minutes, and then we looked at metabolic brain metabolism during the walking. We had like two tasks. We had a straight walking task, very boring for 20 minutes, and then we sent them to the scanner. And then we had another task where they had it was more complex and they had to walk and turn around specific cones. Yeah, and then we send it back home. And so we have these two projects where we're looking at brain activity during walking, and we have another project where we're looking at physical activity and
Mhm.
sleep in their usual environment, right? So so the analysis is still ongoing, but we already got preliminary data. Regarding the brain activity data, so the PET data. And what we typically see is that in terms of patterns of brain activity, so when we look at increased brain metabolism from let's say from the straight walking task to the most complex task, we see that overall, by and large, we have more or less the same change in metabolic
Mhm.
activity from the straight walking task to the complex walking task, which was intriguing because you would think the issue would come more, the differences would show up more when you have a more complex task where you ask them to turn and it's more complex. You think it's more attention demanding, but no, we actually saw differences when we contrast it with the straight walking task. So we see that in terms of increased metabolic activity, we see completely different areas that pop up um, in the group that is fatigued compared to the group that isn't fatigued, and that was actually in line with most of the hypotheses. So we believe that fatigue is more something that is related to motivation, and particularly actions like walking that require internal drive. So in a
Mhm.
complex task that provides additional cueing, that can actually improve performance. Whereas
Interesting.
in a boring task where you ask them to walk straight, we actually saw differences. We saw differences in regions like the middle frontal gyrus, frontal regions, parietal region, like the angular gyrus. Typically, it seems like the default mode network, which is a network that is primarily active in at rest, was it popped up more during the straight walking task in people with fatigue, and that could be seen as them being more, aware of their internal feelings or their own self, potentially engage in self ruminating thoughts, and less directed towards the task that they are doing, which is walking, right? So there seems to be that heightened sense of self perceptions and emotional perception that is going on in the very mundane task. So it doesn't really have to be in those very complex physical tasks and cognitive tasks. It seems to be already there seems to be already a calculation or apprehension of the effort that one is providing or has to provide in a very simple task like walking in a straight line,
Yes.
compared to a task where, oh, you told, oh, you have to turn around here, you're giving cues where, and there we saw that, attentional regions, dorsal attentional regions were similarly activated in the more complex task, although we had some differences. Generally, you had the same pattern for the complex task, but in the straight walking task, we saw different brain regions, and the brain regions that were more activated, more that had more metabolism in the fatigue group were related more to the default mode network, which was intriguing, and
Yes.
also the middle frontal gyrus that has been also linked to perceptions in subjective perceptions of fatigue. So you have these studies that have looked at cerebral blood flow, and then they were able to show that the change in cerebral blood flow during a continuously attention demanding task. So the increase in cerebral blood flow was associated, correlated with the change in subjective perception of fatigue. And we saw that the middle frontal gyrus also popped up in our study. So yeah, so things are in line with the idea that fatigue is more related to this perception, that heightened sense of self and perception of emotion, and 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 an inability also to uh, perhaps to sustain attention to an external task in the long run, where you need to 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 really switch that attention by your own, you know.
Mm.
And when you start providing additional cues, that might sometimes help performance, even though the task might be complex. So that's the current interpretation of our study. And the next thing we want to do is really look at the patterns of walking activities unsupervised, because we also connected gait kinematics, and
Mm.
and so far we were unable to see differences in terms of how the fatigue trait might affect gait kinematics. We don't really see differences in the way the biomechanics of the gait. You know, we don't see differences between those who have fatigue. Even after 20 minutes of walking, it's pretty much the same, you know, and you think that there isn't really a biomechanical picture of fatigue. It seems to be more something that can be pictured in the long run, and for that we want to look more at behavioral activities like physical activity, where we think that motivation, you know,
Mm.
especially that you're at home compared to being in a lab where they're probably more motivated, and we just measuring over 20 minutes. It's not how they behave on a daily basis, so we don't really capture the motivational issues there that could be related with fatigue and apathy. So we hope to see um, more picture of fatigue there in terms of physical activity. And we also measured sleep. It's like, oh, we're sending them home, they might as well like wear the activity monitors at night. So yeah, that's the preliminary result so far, and we're still running the analysis, and yeah, writing the manuscript. Hopefully, the first paper will be submitted and come out soon.
Excellent. I look forward to it. There's just so much there in terms of like what we were just talking about in terms of doing activities that engage the mind in a beneficial way, in a happy way, in a
Yeah,
way. There's so many pieces I think that could be so therapeutically relevant to
yeah,
not only people living with Parkinson's but clinicians. So I know you've got your Instagram and social media handle. Let me
yeah.
ask you, where did the Parkinson blogger come from? Because I thought you were blogging about Parkinson. So tell me very quickly in the last minute or two as we wrap up here.
It's really when I was in my master's in Belgium, there came a point when I was reading so much about Parkinson's in the context of my thesis, and I was doing my specialization in rehab. I thought, why not just put my thoughts somewhere and then post it? So in the beginning, it was really for me to write my thoughts down and put it online.
But you did have a blog then.
Yeah, on Instagram.
Ah, okay, on Instagram.
I didn't really have a blog. Initially, it had several names. My page. It's hard because initially I wanted to do more neurorehabilitation content. So I think my first post was mostly about that. And then I
Mm.
remember I got so, you know, swamped in my master's thesis. And then when I came here, I remembered, oh, I had opened an Instagram account on rehabilitation. But then I really spinned it off to more Parkinson's related content. So I said, I think I took opportunity of the International Parkinson's Day in April, and I was like, oh, it's Parkinson's Day. Let me do a post
Very
and
cool.
that. And then I met you, and then you started telling me more about, oh, Jordan, you should provide more content.
Yes,
I think you have
you've got
substrate for that.
yeah, you've got a lot of knowledge that I think it would be so helpful for people. And so it's at Parkinson.blogger.
Yeah,
Okay,
it's at Parkinson's.blogger. I'm gonna provide more content on Parkinson's and what I do
cool.
as a researcher. Yeah,
That's awesome. And we'll share this and you can share some of this with your audience. So very cool. Jordan, so cool to talk about all the wonderful research that you're doing, and we look forward to it. And we'll continue this conversation. I feel like once the paper comes out, there probably could be a part two that we can talk about.
Definitely.
Thank you so much, and I really appreciate
I'm thanking you, Haseel.
it.